without further ado, I am going to introduce our closing keynote speaker. So Dr. Donna Lynne is the Chief Executive Officer of Denver Health. And I am told that she really needs no introduction. And in fact, she prefers that there really is not a long introduction. So I will just say that she is an amazing woman with great insights who has worked in all different parts of this system, including being Lieutenant Governor for a time. So please help me welcome Dr. Donna Lynne.
Well, thank you, and I promise I will try to be concise. There's a lot to cover, but I would love questions because I think we've got some insights to share, and I've heard bits and pieces of what you talked about today. I'll answer Maisha's question, even though she left. I think we think healthcare is a right. And as my colleague, Dr. Federico, coined, it shouldn't be a fight, but I'm going to tell you about our fight. I think that's partly instructive for those of you who would also like to fight. So thanks for the opportunity to be here. And I know you've had a great day networking, learning from others, and I am going to focus on November 5th a little bit, talk about some of the pluses, some of the minuses, without creating anxiety, what we might be looking for in 2025. But I do want to, as it was requested by the conference, is to talk a little bit about 2Q so that you understand, why did we do it? What is it? How did we do it? And I think it's instructive given, I know there's been a broad discussion around safety nets. I guess I might argue, yes, everybody's a safety net in healthcare because we're catching people, but the traditional and classic definition of a safety net really is what comes from Denver Health, and that commitment to take care of people regardless of their ability to pay. So I'm going to cover a few things in my time. I do want to talk about the initiative, as I told you, to talk about Denver Health because oftentimes, and I'm here with our colleagues from the Colorado Hospital Association, we are so much more than a hospital in terms of being both federally qualified health centers, the ambulance services, et cetera. So I just want to give you a little snapshot. And I know in some rural areas, those kind of services also are bound together. One of the things that makes us unique is everybody is our employees. So we can't go like that contract physician group or that contract anesthesiology group, or, it's one culture and it's one system. And so we take that very seriously, I think, in terms of the care that we deliver and how we approach issues like, is healthcare a right? We're going to talk about a couple of things that are different at Denver Health that we've done in the last year or so, including the fact that we now have apartments, not apartments for our employees, but we have housing for our patients, partly because it's the right thing to do. We do it at with no reimbursement, and it provides another kind of safety net for, as we talk about that intersection between social determinants of health and actual health care. And then I'm just going to talk a little bit about what might be happening. So I was asked to talk about what is now known as 2Q, our ballot initiative, and I want to explain, this is not because we're a safety net. This is not because we have a lot of uncompensated care, which we do. And again, Medicaid growth, the lack of appropriate reimbursement in Medicaid and in Medicare, as well as increasing number of uninsured, creates problems for all hospitals, for federally qualified health systems, for everybody around. But we had a little different situation, and I'm going to share with you some of the history of that. And it comes from what our origin was. Our origin is we were a city of the City and County of Denver agency until 1996. And so to me, when we talk about 2Q, while I think everybody would like to get more funding somehow, to me this is fundamentally about a broken promise between government and a healthcare system. And we could argue, again, Medicaid maybe is kind of like that, and of course what we see in the future is going to be challenging. So let me just show you a nice little slide that we like. And that is to show from 1996, when Denver Health was part of the city and our budget was about $220 million, we got a payment from the city to take care of what they called medically indigent patients. And again, back to our history, 1864, the oldest health system in the state of Colorado, older than the entire state of Colorado and the city and county of Denver. So think about the Platte River, people coming over the mountains to mine, farm, live in Colorado, and we were there at the very beginning. So back in 1996, when we made a decision to separate from the city and become an authority for a whole variety of financial and other reasons, the city gave us $30 million a year to support the indigent. And in 2024, we still get $30 million from the city. Now, what's happened? Oh, I love it. I have somebody whose mouth is wide open. So as you know, the population of Denver exploded during that period of time. Healthcare costs, as you all know, exploded. So we didn't have any even CPI or even any medical inflation built into this agreement. And I came to Denver Health just a little over 2 years ago, and I don't think I knew what I was getting into, but that was okay. But as I looked at it and as I learned about other safety nets, traditional safety nets, like a Cook County or LA County or Parkland or other systems that are defined as traditional safety nets, we learned something, and we learned that, oh my gosh, they have other funding that helps them get through not only some of the fluctuations in reimbursement, but certainly to continue that mission of always serving the underserved, regardless of their ability to pay. So, as I said, Denver grew pretty substantially during that period of time. Healthcare costs grew, and we expanded a lot of what we did. We are in the public schools, and I'll share that with you as we go forward a little bit about Denver Health, but really an explosion, tripling, quadrupling, and quintupling in that period of time in terms of some of our costs. So our budget's pretty big at Denver Health. We're about $1.4 billion. So that $30 million just continues to diminish. It's now about 2% of our budget, whereas back in 1996, it was about 12 to 15% of our budget. We are about the same size as the city and county of Denver, just a couple $100 million shy of being the same size as the entire city. So uncompensated care, we all know this is growing. It's growing in Colorado, it's growing nationally, and it's a huge problem. So the combination of uninsured patients as well as the shortfall in our public program creates some big problems for us. And for Denver Health, we have seen just in 4 years a tripling of our uncompensated care. And that is because of more people, and also, as you heard, and I think you're all aware, certainly with the discussion around the governor's 2025 to 26 budget, getting no increase in Medicaid provider rates is in essence a decrease. So we're seeing inflation. We have to pay our employees. We have to pay more for pharmaceuticals and other things. So 2025, 26 is going to be even more of a problem. So this chart shows you, I call this my favorite chart, and you can see this spike in 2019, we had about $60 million of uncompensated care, and we were getting $30 million from the city, but today we have $155 million in uncompensated care, and we still get the same $30 million. Now, some systems calculate uncompensated care based on charges, which is fiction. No, we don't get paid charges. This is based on costs. So this is a fairly conservative definition of what our uncompensated care is. All right, so we serve, we're called Denver Health, but believe it or not, we serve the entire state of Colorado, every county except for 2. So we're in Montezuma County patients somehow make their way to Denver Health, Baca, Prowers, you name it. And that was quite frankly part of our debate with the legislature. The legislature did see their way to give us a very small payment in 23 and 24. They removed that in this proposed budget, which creates a real problem for us. There are hospitals and health systems in all of those counties, but somehow we are taking care of many of those patients. About a third of our patients come from outside of Denver. All right, and this just shows you a little bit. I want to talk a little bit about safety nets, because again, I've heard the term here. Whether you call them safety nets, you call them essential health systems, again, there isn't a formal designation, except for the fact that we look at, your percentage of uninsured, your percentage of government programs, and others, and that commitment to take care of patients regardless of their ability to pay. According to, now Wikipedia is not the best source, but I did happen to look this up. But according to Wikipedia, there's one safety net hospital in the state of Colorado. It is Denver Health, and there are only about 130 in the entire country. But again, I get it, that our rural hospitals, which we partner with a lot in particular, face some of the same kind of challenges and the inability to invest in infrastructure. And that certainly is one of the motivating factors for us thinking about how do we get more funding to Denver Health, because we're unable to invest in new capital, and we need to do that. Whether you're in Lincoln, Colorado, or you're in Denver, patients deserve high quality, decent facilities in where they can get care. We spend a lot of time on social issues known as the social determinants of health. As you know, I mentioned housing. So we have 34 apartments we move patients into for up to 90 days because it's the right thing to do. It avoids them coming back. Potentially with complications, but we do this because it actually makes sense economically. We have a lot of long stay patients. You heard Senator Doherty talking about mental health and substance use, and some of our patients actually on the inpatient setting, about 20% of them are homeless and they don't have a place to go. So discharging them is cruel, and it creates more of a problem from a healthcare perspective. So there's a lot of work that we do when we have a patient who either signs up for the first time at Denver Health, or for every visit, they are asked about their income, they are asked about their family size. Then we deploy our teams to work on some of the other social determinants of health, whether it's transportation, it's food, or housing. So I mentioned this journey on what we did, and let me explain what 2Q was. But it was partly motivated, as I said, by talking to other safety nets around the country. And what we found was that on average, they get about 11% of their budget from their local government, whether it's a county or it's a city, contrasted with what we get from the city and county of Denver, which is 2.4%. So I'll take you through this journey. It was interesting that Maisha led with the question. So Dr. Federico coined the phrase, healthcare should be a right, not a fight. But as I said, we decided to fight, and we won. Thank you. So let me talk a little bit about the ballot measure. If you didn't live in Denver or you don't remember voting, we were very clear. First of all, there was a lot of work that we did to get to this place, about a year's worth of work. And I think a lot of engagement with key stakeholders across the entire city, and in fact, in some cases outside of the city, to deal with that other issue of care that we provide for people that don't live in Denver. So here's what the ballot measure looked like. And in essence, what it was a sales tax increase. Not thrilled about that, but it turned out that our polling demonstrated that people were so adverse to property taxes, and as you know, we've seen some pretty significant increases in property taxes. And so sales tax polled better, even though it's regressive. And we tested various levels. We tested city versus a metropolitan area. And we also tested what were the things that made people want to support a ballot measure. So we found 0.34 or 3.4 cents on a $10 purchase is where we landed. That's actually higher than most sales tax initiatives that have been passed in the city and county of Denver. They tend to be 0.25. And we did it because actually there was literally no difference between 0.25 and 0.34 when we asked voters. So we said, we know we need, if you think back to that slide, $155 million of uncompensated care. We knew that this 3.4 cents would generate only 70 million, so roughly 70, probably a shade under, plus the 30 million that we get from the city still left us with a problem to solve, and I'll explain how we try to do that. But we also wanted to give the voters, the council, and the mayor the assurance of how we would spend the money. This wasn't a checkbook. We didn't say, just give us some money because we take care of people regardless of their ability to pay. We didn't say, give us some money because we're good people. We also tried to communicate our own accountability and transparency around what we were doing. So we specified the areas where the money would be directed to. And so you can see on this slide, not only the formula, but the where does the money go? And it goes to primary care, pediatric care, it goes to mental health and substance use, and it goes to emergency and trauma care. So, and we will report to the city every year on how we spend the money and how we deliver outcomes based on that spending. I've often been asked, is that enough money? And the answer is absolutely not. It's not enough money. But again, the tolerance level behind what we thought we could ask for voters. So as I said, how did we do this? So it was a year-long effort of thinking about how do we learn and how do we teach others, particularly stakeholders. So we convened a stakeholder group of a lot of influential people. We taught them about Denver Health. We taught them about healthcare finance in general. We introduced them to other safety nets around the country, and then we said, you go to work and come back with some recommendations, and they did. What I learned, certainly, and I think you'll hear in a few minutes, is most people don't know what we do. And that's why I always like to lead a lot of conversations and say, Denver Health is not a hospital. We are so much more. So we're actually in 50 different locations. Would that surprise most people in this room? Yeah, because you think about 8th and Bannock, and there's an emergency room and a level 1 trauma care, and you see the ambulances going in. We're really proud of the work that we do in that 550-bed hospital, but we're actually in 50 different places. We are in 10 community clinics around the city. We are in 19 public schools. We have a safe center for children who are abused. We are part of the foster care system. We are in the jails. We have a detox facility that's separate from the hospital where you don't need hospitalization. We have public health clinics to deal with HIV patients. We are the front line for any infectious disease that comes not just to Colorado, not just to Denver, not just to Colorado, but into actually a multi-state region. So we have a biocontainment unit. When there's a suspected Ebola case, it comes to Denver Health. So just to give you a perspective of what we needed to educate these stakeholders about and what we needed to try to educate the public. Now here's the challenge. I always say there is no elevator speech about this. And a lot of people would say as we were going through this, well, you're taking care of migrants. Yes, we are. And actually, so are a lot of other systems in the state. But that's not the cause of the problem, and that's not why we were looking for additional funding. And I think, as you heard Senator Smallwood say, and I've had the pleasure of working with him, he's quite a good guy for a Republican, right? He believes in universal care. He recognizes that we're much better than providing preventive care than we are for waiting for people to get really sick. And I think Senator Daughtry talked about that as well. So what did we do? I mean, it's interesting. I learned a lot running a campaign personally, that we then transferred to what we did for Denver Health. So you need to create, even if you can't have an elevator speech, you need to create some consensus that this is an important issue or an important person to support. We actually, because we're a governmental authority, we could not spend any Denver Health money to do this. So we had to set up a separate organization. We use that organization to do some education awareness. I used to say to Jeff Tiemann and some of the other hospitals in Colorado, we do not need any more patients. This is not Coke versus Pepsi. This is telling people what we do. We had to reach out to, as I mentioned, this stakeholder group of 30 people in every city council district. We had the mayor's team ex officio on this group. And then once they came up with a recommendation, we had a process to follow internally, and then we created a business advisory group. Why? Because businesses are generally adverse to more taxes, but we got the buy-in from 60 business leaders whose names, everybody in this room would likely recognize. We then needed to actually run a campaign. So, as I said, set up a separate organization, think about advertising, think about social, think about, sign waving, all the things that happen in a campaign. And it was quite an effort on our part. So one of the important parts about doing this was getting the support of government. So we had 6 of our living mayors support us. We had Senator Hickenlooper, Senator Bennett, Congresswoman DeGette, the entire Colorado state delegation for Denver, and even for surrounding counties, and even for different parties. I mean, there was such a recognition of the work that we needed to do. So what I want to do now is talk a little bit about, I've touched on a few parts of Denver Health, but I want to this is just our team celebrating. I was waving signs too and eating tamales with people and doing all the kinds of things you do when you're running for office. All right, so let me just bridge quickly to Denver Health, and I covered a lot of this in terms of what we are. We're very proud of the fact that we deliver 1 out of every 3 babies. We are a level 1 trauma center, as I mentioned, and I mentioned some of the other literal locations. We are in what's called the inverted L in Denver, so the Health Equity Index designates the north and then down South Federal. That is where the majority of our clinics are located, as well as in the schools. 1/3 of our patients have had behavioral health or substance use issues. So as you heard, the challenge in dealing with that population, it's not fixing a broken arm, it's not fixing a broken heart, although we think we do those things really well. It is dealing with some very, very complex patients. So just to give you a perspective, and I want to quickly get to some questions, one of the things when I came to Denver Health, I said, gee, what is our mission, vision, values, et cetera? And we went through an extensive process to think about what did we want to be. And we came up, and trust is now used a lot in healthcare. It's used in a lot of other institutions. What do we want to be? We want to be the most trusted healthcare provider. With all due respect to everybody else, you can adopt the similar thing, it's okay. But we wanted to be trusted, not just by our patients, but by our employees. That was really important. As you all know, having gone through COVID and some of the challenges, being trusted by our employees was very, very important. So what does our population look like? I think this is really a helpful slide. We serve disproportionately lower income and minority patients compared to the state. So about 55% of our patients are Latino. Language diversity is huge at Denver Health. We not only have a substantial number of our employees who are bilingual, but we have over 190 languages that are spoken and that means we spend a lot of money on language line services. And you can imagine, this isn't learning how to say hello and how are you. It's actually, medical, being able to converse medically. Our electronic medical record is in multiple languages, and we're always seeking to improve that. So this is a slide that comes from HCPF. I did not make this slide up, but I want to share with you what makes the challenge that Denver Health has so unique, and that is, I call it sort of the trifecta. I'm going to stand on my toes so I can actually see this. I'm a little short for that. So we have the lowest percentage of commercial patients amongst the key systems in Colorado. 14% of our patients are commercial. And as you know, that's the way you often balance some of that uncompensated care that you get. We have the highest percentage of Medicaid patients as part of our payer mix. I know other systems will say we've got more Medicaid patients, but to me, there's a numerator and a denominator, and that's what's important, because that's what makes this balancing so difficult. We don't have a lot of Medicare patients, so we have a lower percentage of that. But between the self-pay and the CICP and other category, we're in the 17% range. So this is what makes it so difficult, not only financially, but oftentimes in terms of the services that we provide. I'm going to skip this. I mentioned housing and our two locations where we do provide housing. One is right adjacent to the main campus. We're in the Denver Housing Authority building, and we have the whole second floor. We work with patients who who would normally be long-stay patients at Denver Health. We get them into the housing for up to 90 days. We work with the Housing Authority to get them vouchers into more permanent solutions. And then the other location that we work with is the Colorado Coalition for the Homeless on South Street. These are patients with a little bit more acuity, and some of the medical services that they get at the coalition are an important part of that relationship. You all know when you all do this, I'm going to skip through this quickly, how do you make this all work? And, as I talk about housing and long-stay patients, it reminds me of the fact that what we don't have in Colorado, or maybe in the United States, is we don't really have a healthcare system, right? We have silos of people who do certain things, but we often don't have the system that allows us to succeed. And I would argue that we need a strategy in Colorado, particularly around long-term care, where we don't have enough providers, where their reimbursement is also extremely challenged. But it's not just true, it's true for Denver Health, it's true for other organizations, particularly some of the rurals. I mean, you cannot just discharge a patient and not know where they're going to go. And I think that's part of a moral dilemma that we all face in healthcare. And so rather than talking about saving people money on healthcare and some of the other things that I know we do in this state, my argument is we ought to talk about how do we build a system that's responsive to the needs of patients, and how do we start having those conversations. All right, I think there's a couple of really exciting things that we've done at Denver Health. We have a first in the state surgery program around aortic aneurysms. We are now using a Da Vinci robot. I mean, one of the things we want to make sure as we communicate about what Denver Health does is that's where I get my care. That's where Mayor, now Senator Hickenlooper gets his care. Mayor Hancock. I could go through, I'm not committing a HIPAA violation. They would all tell you this. And so we have to be able to invest in the same technology that other systems actually have. And so we decided to roll the dice and get a Da Vinci robot. We've done over 150 surgeries this year using the Da Vinci robot. We've invested in artificial intelligence, which everybody's talking about. That could be a whole nother section, but really important to be able to both improve patient satisfaction and physician burnout. So we use an organization called NABLA that is doing all of our scribing work now. And then another thing we discovered when I came to Denver Health is we didn't talk to our patients. We now do that. We have a newsletter. We see 280,000 patients a year. they, in this campaign that I described, hopefully a lot of them voted because they understood what we did. We also are an academic medical center, and so much like the University of Colorado, we train physicians, we train nurses, we train lots of our staff, and create a pipeline for employment, and we do a tremendous amount of research, about $100 million worth of research a year. I'm going to skip ahead because I do want to talk about some of the work that we do in disparities. As I mentioned, the population that we serve is pretty different than many other hospital systems, and we take advantage of the fact that we can actually communicate with our patients, get them enrolled in clinical trials, and we've changed some of our practices based on some of that knowledge. All right, last thing I want to talk about is I want to talk about the future, and then happy to take questions. So I know everybody's anxious. We're anxious, although we're trying to think forward thinking. And as you know, the Affordable Care Act for many of us was a lifesaver, particularly for Denver Health. We actually made a little bit of money for a couple of years in 2020 and 2010 and 2011. But as we've seen the PHE unwind in Colorado, it's had a devastating impact on a lot of our finances. We've seen an increase in the number of uninsured. We've seen those who have stayed in Medicaid actually have more acuity, and so in our case, we have both a health plan as well as a delivery system, and so we're finding that those who are staying in are utilizing care at much higher rates than we were used to. We're all worried about the subsidies. We participate as a health plan on the individual exchange. It covers over 100,000 people across the state. We have a significant number of them at Denver Health, and if the subsidies aren't extended by Congress, we will find people dropping out of care. And as you know, the sort of typical areas that everybody's been talking about, Title X, family planning services potentially coming to an end, certainly things like gender-affirming care that we do at Denver Health. We do pregnancy terminations as of this year. And in general, we're just concerned about what will happen to Medicaid. That's probably the biggest challenge that I think that we're all facing with a state environment where the funding is being held flat, and we could be facing additional cuts. So what does that mean for us? What we got on Election Day was a wonderful thing. What we might lose as a result of Election Day could be even greater than the additional revenue that we are picking up through this initiative. So I think we're all concerned with our colleagues across Colorado in the Colorado Hospital Association, with our colleagues in CCHN, and even with the Medical Society. I think what the call to action from my perspective is we've all got to hang in there together. We've got to think about solutions and how we move forward in trying to keep, and I'm going to call it the safety net, the entire safety net for the state, and to keep Colorado a healthy place. So with that, I don't know if Joan is moderating or I'm on my own. Am I on my own? And I like this quote, so I thought this was an important one. As you heard Jim talk, which is always interesting, Jim Smallwood, we need universal coverage. We're not going to get it in this country, certainly in the next 4 years. It's dangerous to try to do it in the state of Colorado. I'm convinced of that because businesses are much more portable, employees are portable, but we have to do everything that we can to make sure that we have a system and that we're all working together. So I'm going to, I guess I'm all by myself up here. Joan, where'd you go? I'm happy to take any questions about any of what I tried to cover in this closing. Oh, she's over there. Sorry, Joan. That's not a question. That's one of my ringers. Like Rhonda brought a ringer.
Kyle Garrity. I work for Health First Colorado Medicaid. And you mentioned a couple of times that this is a safety net hospital for state of Colorado. I happen to be also a resident of Denver. Interested, I really had a hard time with this one because I kept wondering to myself, why is this not being put out to the entire metro area or maybe the entire state? And I would just be interested, to learn from you why that was.
Yeah, it's a great question, and it's one of the most frequently asked questions. Why did we ask the residents of Denver to pay for this? So two things. First of all, we did poll the metro area, so we polled 7 counties. The support was good. I was actually very pleased to hear the support we got from the voters. But it didn't poll well enough for our campaign advisors to say, the worst thing to do is put something on the ballot and have it lose, right? You can't come back. I mean, it's multiple years before you come back. So the polling showed that we had a much stronger chance if we just made it citywide. Now, the truth is that the sales tax in the city and county of Denver, a third of it is paid by people who don't live in the city and county of Denver. So they're here for a Broncos game, they're from Alabama, they're coming in. So from an equitable point of view, actually, we were getting sales tax from people that don't live in Denver. I wish that the relationship between Denver Health and the city did not take us to this place. I mean, I think that, again, back to why did we do this, that I think there was a compact, there's an actual agreement between the city and Denver Health that I think the spirit of it was never, the spirit of it was not held. And you can imagine 26 years of asking for more money when you contribute so much to the city in terms of the social and economic well-being and not getting more money. Some people said, SCFD, the Scientific Cultural District, where it is a regional tax, could have been a model, except money goes right back. You collect the money and you give it back to museums and cultural institutions in those counties. And the perception wasn't that was what was happening. Denver Health, as a city and county entity, was getting the money. The other part of it is we did try several times, not just during my tenure, but in my predecessor's tenure, to point out to the counties that in particular send a lot of patients to Denver Health, hey, this isn't fair, here's a bill. Nobody ever responded and said, here's your check. So we knew that was not a great strategy. Now, the strategy that we did use was we went to the legislature and we said, hey guys, we are taking care of people in 62 of 64 counties. And we need some acknowledgement of that, because it's a third of our uninsured patients. It's not just, it'd be wonderful if a commercially insured patient in Telluride, and we do have patients from Telluride, a commercially insured patient from Telluride, came to us. That's not who's coming to us. It's uninsured patients. So there's something wrong. I don't want to go too much deeper on that, but we could be a statewide entity. I don't want to take that on because then we'd get even more patients potentially from around the state. But the legislature at least did say, here's $5 million. And I know that created some concern, like, wait, why is Denver Health getting this money? Because I don't think any other system could say that a third of their patients are coming outside of their service area and a third of their patients and third of those are uninsured. One more question. All right, I think you get early dismissal. Thanks, everybody, for the opportunity to be here.